to ATCM, the emergency medicine channel. 20-year-old female with no comorbidities presented to ER with complaints of generalized tiredness and dyspnea on exertion for the past 3 days. Initial 10-second assessment, patient conscious oriented, obeying commands, airways patent with no gargling of secretion, stridor, able to complete 1 full sentences, breathing, respiratory rate of 20 per minute, saturation of 98%, bilateral air entry present with no added sounds. Circulation, BP of 110/70, pulse rate of 100 per minute, all peripheral pulse palpable. Disability GCS of 15/15 with pupils equal and reactive to light. Exposure temperature of 98 degree Fahrenheit. Adjoint to primary survey, we did a CBC-CRP point of care which shows total count of 5, platelet of 297 and HP of 7 with MCV of 76 and MCHC of 28. On VBG, no acute acid base disorder, and with a lactate of 2 and ECG showing sinus tachycardia. History, 20-year-old female with no comorbidities came to ER with complaints of generalized tiredness and dyspnea on exertion for the past 3 days with associated occasional palpitation. There is no history of chest pain, syncope, orthopnea, PND, fever, dysuria, ataxia, mucosal ulceration, altered mental status, no history of loose stools, vomiting, abdominal pain, abdominal distension. But patient gives history of excessive bleeding during her periods, having had to change almost 8 to 10 pads a day, lasting for 4 to 5 days for the past 2 months. Currently, she is on her 3rd day of periods. No known drug allergies. Then on general examination, patient conscious oriented, pallor present, no lymphadenopathy, edema, pedal edema, pedal edema, then icterus,
Okay.
clubbing, cyanosis.
What is your preliminary differential diagnosis from the patient's history?
Patient presented with complaints of tiredness, dyspnea and exertion with an HP of 7.
That's investigation. With this history, what is your differential diagnosis? Just the history.
It's an adolescent female with excessive blood loss for the past 2 months, menorrhagia, complaints of generalized tiredness and dyspnea on exertion. Most commonly, like anemia.
Anemia. You are going to first primary diagnosis is going to be anemia. What type of anemia? Most probably
iron deficiency anemia.
Most probably iron deficiency anemia is your first DD. What will be your second DD?
Second DD, like normocytic, normochromatic, blood loss can.
Anemia is over. What is the second DD?
20-year-old female, generalized tiredness, any other leukemia, hematological man.
Second DD, leukemia. Okay, leukemia. Third DD.
Any abnormal cardiac complaints.
It's a young female, 20-year-old. It can be arrhythmias. It can be arrhythmia. She is complaining of palpitation, generalized tiredness. Maybe she is having multiple episodes of arrhythmias happening. So arrhythmia is a possibility. What else? What is your fourth DD?
Hypothyroidism.
Generalized tiredness, decreased activity, hypothyroidism. What is one thing in your history that is against hypothyroidism?
Tachycardia.
Heart rate of 100. That's what's against this thing, but she is having menorrhagia, multiple episodes of periods in a month. So hypothyroidism is a possibility here, except heart rate of 100. Okay, but still heart rate of 100 can be explained if she is having iron deficiency anemia. But that combination we need to keep in mind. If that menorrhagia history was not there, then what will be your DD? Will it be hypothyroidism or hyperthyroidism? Patient is having tiredness, palpitation, breathing difficulty, anemia, can be hyperthyroidism also. So this is a basic differential diagnosis initially. Then you evaluate the patient. Okay, so once you get the this much DDs, now you have got some certain things to rule out, right? You need to look for hypothyroidism features, hyperthyroidism features, and you can look for any iron deficiency anemia features. You have already mentioned that she is having tachycardia, she is having pallor, she doesn't have icterus.
Yes.
Why did you mention icterus?
To rule out hemolysis. HP is only 7, so it's anemia. So if icterus is there,
hemolysis is a
hemolysis.
possibility. Even if hemolysis is there, it is a form of iron deficiency anemia only, isn't it? Chronic hemolysis can happen, especially in patients taking drugs. What are the drugs that can cause hemolytic anemia?
Drugs such as
Neurological drugs.
phenytoins.
Levodopa, not phenytoin. Levodopa, Parkinsonism drugs can cause. Then
infections.
antibiotics, cephalosporins, levofloxacin. Cephalosporin, levofloxacin, people won't be taking long term, but there are possibilities of cephalosporins induced hemolysis as such. But levodopa is a constant, is a drug that can cause significant hemolysis as such. Okay. So you are ruling out hemolytic anemia with the icterus. Okay. What are the other major examination findings you will be looking for?
Looking for bilateral pedal edema.
Why you want to pedal edema? If bilateral pedal edema is there, what will it mean?
Cardiac failure, congestive
Most
cardiac
probably anemia has caused congestive cardiac failure. If there is bilateral pedal edema, what other signs will you look for?
elevated JVP
Elevated JVP and
breath tachycardia, wide pulse pressure.
wide pulse pressure, tender hepatomegaly.
Hepatomegaly.
This is congestive cardiac failure features you will look for. Okay. Now there is no pedal edema, no pedal edema. What other clinical examinations do you want to look into? If there is hemolysis happening, splenomegaly, hepatomegaly, splenomegaly, isn't it? You are one of the DDs for leukemia, right? So splenomegaly is an important clinical finding you need to check in this patient. Okay, so these are your clinical findings and all. Anyhow, you have done a point of care, and point of care had told a hemoglobin of 7. So with just your point of care, how can you classify anemia?
Anemia basically classified with the MCV, mean corpuscular volume. We can classify anemia into normocytic anemia, microcytic anemia, and macrocytic anemia. So MCV, if it is less than 80.
What is the normal value of MCV?
80 to 100.
80 to 100. So less than 80 is microcytic.
More than 100 is macrocytic.
Okay.
So if less than 80, then we'll go for we'll go for serum levels, serum ferritin levels.
That you can go, but you have CBC with you. You told MCV, which is correct. What is the next test you are going to look in the CBC? MCH. So MCV, MCH, right? MCV is volume and MCH is mean corpuscular hemoglobin level. So if MCH also like MCV, you can categorize as low, normal, and
high.
High is not there.
Sorry. Low and
normal and low. There is no high MCH. Okay. So if your MCV is less than 80, your MCH is less than 32, you can say that patient is having microcytic hypochromic anemia. Basically, iron deficiency anemia. What was this patient's MCV, MCH?
MCV is less. Our patient's MCV was 72 and the MCHC is 28.
So it's a microcytic hypochromic anemia. So now you have a iron deficiency anemia in your hand, right? Okay. How do you go ahead and evaluate iron deficiency anemia?
The next step is we have to look for serum iron, serum ferritin, and total iron binding capacity. So if serum iron is also less, serum ferritin is also less, with high total binding capacity, we'll go for iron deficiency anemia. If it is iron and ferritin is low, but TIBC, the binding capacity is also low, then we'll go for anemia of chronic disease. Then we look for Minsk index, that is MCV by RBC level. If it is less than 13, we'll go for thalassemia, which is also an microcytic hyperchromic anemia.
Okay, so basically, you will once you get a anemia and your MCV, MCH is low, you're basically suspecting iron deficiency, and for confirmation is what you are sending these things, right? So you want to know the serum iron level, and if iron levels are really low, means is the reserve low or is it really low? Because you want to think about replenishing, how to replenish the store, right? Whether you want to give IV or oral is adequate, that question has to be answered. That is why serum iron levels are important. Obviously, along with that, you want 3 more things. You want ferritin levels, which should be very low because iron is low, and TIBC, that is total iron binding capacity, which should be very high because body is lacking iron, so TIBC activity should be very high. And along with this, you will look for reticulocyte index. These are the things that you take for iron deficiency anemia. So once you get these values, and as you told, serum iron low, ferritin low, TIBC elevated, iron deficiency, it's a clear cut, you can go for management. Second thing is serum iron low, ferritin low, but TIBC is normal. That is anemia of chronic illness. What are some of the chronic illnesses that can cause anemia of chronic illness? CKD, CLD, any organ, any chronic organ failure will cause iron deficiency, means anemia of chronic illness. What else in India? What else? In India, what else? TB. TB, a latent TB in your body can cause iron deficiency anemia. Extrapulmonary and pulmonary will cause iron deficiency anemia. What else? Malignancies will cause iron deficiency anemia. And other sarcoid can cause iron deficiency anemia. Autoimmune diseases can cause iron deficiency anemia. Okay, all these things can cause iron deficiency anemia. Then you told something, Metzger's index, right? Okay, so what you are doing? You are dividing MCV divided by RBC count. And you should get a value more than 30. And if it is more than 30, it's iron deficiency anemia. And less than 13 is thalassemia trait. Why? What is the idea of that index?
RBC will be small in thalassemia.
So in thalassemia, basically, even though you will get MCV is low because all RBCs are smaller and fragile. So their volume is low. Because of that, MCV is low. But the RBC count will be normal. So when you divide MCV divided by the RBC count, since RBC count is preserved, you will get a lesser value, making you suspect thalassemia trait. That's all. Okay. So this is your MCV less than 80, right? Now you have normal levels. How does that go around?
If it is between 80 to 100, we'll say a normocytic anemia. Then we will look for reticulocyte count. If reticulocyte count is more than 2%, that means our body is already compensating the loss of RBCs. So it will be either hemorrhage or hemolytic anemias. If it is less than 2%, that is, the body is not at all producing able to compensate the loss of RBC. Mostly bone marrow issues like aplastic anemia or leukemias or pure red cell aplasia.
Okay. So basically, easiest thing is normocytic anemia is usually seen in acute conditions, acute hemorrhage and acute hemolytic anemias. If patient's history doesn't support any acute events, then you are looking for a chronic bone marrow cellular RBC destruction conditions. Okay. Now coming to MCV more than.
If more than 100, we will go for macrocytic anemia. Most commonly, megaloblastic anemia. We'll do a peripheral smear and look for segmented neutrophils. And if it is persistent, there is persistent megaloblast there in peripheral smear, it will be most commonly vitamin
neutrophils. It will be vitamin
B12
and folate deficiency, isn't it? Okay. What are the conditions that can cause megaloblastic anemia? Or what are the drugs or other things that can cause megaloblastic anemia?
Most common in India is alcohol. Alcohol can cause megaloblastic anemia.
Alcoholism. Alcoholism is one of the most common causes of megaloblastic anemia. True. What else?
Then intrinsic factor deficiency, absorption of B12 will be less, so B12 deficiency. Nutritional deficiency.
Let's talk common stuff.
Nutritional.
Nutritional.
Pure vegetarians.
Pure vegetarians, correct. Pure vegetarians can develop megaloblastic anemia. Good. What else? What is one of the leading diseases of India? In the world, in India, leading disease.
Diabetes.
What is the diabetic drug that will cause
megaloblastic anemia?
metformin. Metformin can cause. Chronic metformin use can cause. Then
other
acid modifiers, long-term PPA usage. Long-term PPA usage can cause megaloblastic anemia. What else?
hypothyroidism can cause.
Hypothyroidism can cause. What else? The drug that you told earlier.
Phenytoin.
Phenytoin and other levetiracetam. Sorry. Phenytoin and phenobarbital. Phenobarbital can cause megaloblastic anemia. What else? One of the common stuff that you see here, rheumatoid arthritis patients, methotrexate causes megaloblastic anemia. No? That's why you give folate.
Supplementation.
You will be surprised to hear that. Then
pyridoxine deficiency.
Maybe. Then what?
Lead toxicity. Toxicities.
Toxicities.
Copper deficiency, lead toxicity.
Heavy metal toxicities can cause megaloblastic anemias. These are the other conditions that can easily cause megaloblastic anemia. Okay, so we have segregated into multiple things. Now, investigations, only this many things are there, and a peripheral blood smear for documenting the diagnosis. How do you want to manage?
In case of iron deficiency anemia, if it is less than 8 with a symptomatic patient with congestive cardiac failure, we can go for blood transfusion, or we can treat it with IV iron supplementation.
Or not, you have to give IV iron supplementation. Why you are giving PRBC?
Rapid correction, like HP loss. If it is acute blood loss, anyway we have to go for PRBC too.
You are talking about first thing, no? Iron deficiency anemia, right? Microcytic hyperchromic anemias. In that, why do you want to give PRBC, or when do you want to give PRBC?
Patient is tachypnea, dyspnea, symptomatic patient with impending congestive cardiac failure.
So patients in cardiac failure is when you want to give PRBC. Why? Because you don't want the patient to go into failure. That is the reason why you give PRBC. It's not for iron deficiency anemia correction. Okay, it has nothing to do with anemia management. That is for heart. Okay, so will you give PRBC for everyone?
No.
Who will you give? Don't tell cardiac failure patients. Who will you give?
Severe anemia less than 7. Less than 7 to maintain a target more than 7, we have PRBC. Less than 7, it is.
So you are having a hemoglobin. This girl having a hemoglobin of 7. You are going to give PRBC? No. Iron deficiency anemia. When will you give PRBC? Patient is having CAD. You have to give PRBC. Patient has ischemic heart disease. So if the more anemia persists for him, the more chance he will develop a ischemic event due to the oxygen deficiency, or he will go into failure. So CAD patients you have to Pregnant ladies you have to. Okay. These are the two patients you have to give BRBC. Other patients, as you told, you have to look for signs of cardiac failure. If cardiac failure is there, then only you need to transfuse. Okay, otherwise you don't have to transfuse. Okay, and then you will start IV correction. How will you? What is the dose?
IV ferritin, we can give IV dose up to 100 microgram we can give with like OD for first 3 days and then once a week or tablet form also we can.
Tablet form we will have to first initial reservoir filling we have to do. So that is
we have
IV
to
correction.
calculate total deficit.
Yeah, calculate total deficit is important. How do you do in ICU?
We have an equation called Gansoni's equation. Basically, it is target hemoglobin minus actual hemoglobin of the patient into 0.6 plus 500 is the iron stores that we have. So, target hemoglobin for the patient is 11 minus, if we have not 7, plus 500. It usually comes like whatever.
Whatever we.
So, 1 ferric carboxymaltose contains 500 mg. So, we correct it over 2 to 3 days. Whatever deficit it comes, suppose it comes around 900, we'll give 2 corrections, 500, 500, we'll give a total of 100. With that tablet,
Oral tablets has to be started along with it, but IV correction has to be done initially. Okay. So when you give IV correction, what are the important things you need to keep in mind? Anaphylaxis. Allergic reaction, in some cases anaphylaxis is a real possibility. So our first dose of iron correction should be under observation. We should not start the fluid and go away. Okay. So IV correction and then tablet. Along with tablet, what you have to give? Folic acid. Why you want to give folic acid?
Absorption of iron with folic acid.
Absorption of iron is the
Maturation of iron.
maturation is there. If you don't give folic acid, what will happen? Folic acid will be used up from the stores. Will cause neuropathy. Neuropathy will be used up because the moment you give iron, bone marrow is ready to produce RBC. Okay, see, there is no bone marrow issue. So bone marrow is just waiting for iron to produce. The moment iron production starts out, body will use up folate. Patient can go into folic acid deficiency causing neuropathies. Okay, so folic acid should be added for all cases. So that is iron deficiency anemia, isn't it? Okay. In emergency department, what is the importance of iron deficiency anemia?
CAD heart failure.
CAD patients, if they are also having iron deficiency anemia, presenting you with ischemic event, not only ischemic event you have to treat, you have to treat the iron deficiency also. That means BRBC transfusions will come into play. That is one part. Secondly, toxicity. The chronic anemia, especially megaloblastic anemia, if it is coming and you can't identify a clear cause, you should think about heavy metal toxicities. And another thing is megaloblastic anemia. There are a lot of drugs that cause megaloblastic anemia. So if a patient who is presenting to you new onset tiredness, weakness, exertion, dyspnea, and apparently he doesn't have a bleeding tendency or blood loss tendency, when you look for iron deficiency, when you identify that there is anemia, you have to look his ongoing drugs to see whether it's a drug-induced anemia. Most of the other investigations and treatment can be avoided if you just change the drug. Okay. What else? Patients can be on heart failure, and the drugs that you give can worsen heart failure. So these are the emergency departments, what to say, correlation with iron deficiency anemia. Otherwise, iron deficiency anemia is not an emergency treatment point, right? Okay. Anything else to add? What is the normal ferritin levels? Normal ferritin, TABC, iron levels.
Normal ferritin level is 20 to 500 in males and 20 to 200 in females, and iron is 60 to 170 in males and 50 to 170 in females, and TIBC is 250 to 450, between 250 to 450. And we can also look for transferrin levels,
Mm.
which should be less than, which should be in 20 to 50 percentage. If it is less than 20, it's more iron deficiency anemia transferrin levels.
Okay. Tell me some more conditions in which ferritin will be elevated.
Sepsis.
Sepsis.
HLH.
HLH.
Infection.
Sepsis, she don't know. Just simply asking a little. HLH, sepsis. Then autoimmune conditions. So ferritin alone doesn't tell you that elevated ferritin can be a
Marker of-
what I meant is, even if a patient is having iron deficiency anemia, ferritin can be elevated, because a patient coming to emergency medicine usually will not come with iron deficiency anemia. They come with other conditions, and those conditions can cause false elevation of ferritin. So you will get a low iron, elevated ferritin with elevated TABC, or normal TABC if there is sepsis. Sepsis can suppress TABC. You will have a completely different picture. Okay, but you have to understand the ferritin can be affected by other conditions, so that that should be subtracted out to identify a hidden iron deficiency anemia. Right. Anything else? Nothing. No.